Good afternoon, everyone. Welcome back to our second webinar for the ASEAN Society of Pediatric Anesthesiology Pediatric Pain Special Interest Group. And this afternoon is our second webinar series, which titled Pediatric Perioperative Pain Management. Without further I will invite our moderator for today, Dr. Anuradha Ganigara, MD. She is the Associate Professor from Department of Anesthesia, Indira Gandhi Institute of Child Health, Bengaluru, India. Dr. Anu, the screen is yours.
Yeah, am I audible?
Yes,
okay.
Dr. Anu.
Yeah. Thank you, Dr. Adi, for the warm introduction. So heartfelt greetings to all of you who have joined this webinar. I see that there are around 153 participants, and we are absolutely thrilled to have all of you here as from the speakers and the panelists side. So especially on a Saturday, on a webinar, on a Easter Saturday evening, seeing all of you is extremely exciting. So today's webinar is Pediatric Perioperative Pain Management. And as part of ASPA PPSIG, we wanted to do this webinar to basically highlight on why pediatric pain, despite so many advances over the last 40 years, it still continues to remain, it's often neglected, poorly addressed, and obviously inadequately treated. So today, for the next 1 hour, we have this amazing panel of 4 women in national and international levels who are going to take you through this entire journey of pediatric perioperative pain management and give you some expert tips on how to assess pain appropriately and obviously treat it as well. And just to wrap up the entire, the aim of the webinar is to make pain matter, make it understood, make it visible, and finally make pediatric pain better. So before we start the webinar, I'll just give you a quick run through some housekeeping rules. So this is regarding the Q&A session. So we have a separate Q&A session at the end of the webinar. And I would request all of you to send your questions or comments via the Q&A section. You can direct it to the appropriate respective speakers as well. The chat and raise hand functions are disabled currently. Myself or Dr. Eddy, we will highlight your questions to the appropriate speaker. And if at all some questions are not answered, we'll make it a point that these questions are answered via the website and we'll put it in the next couple of weeks or so. And we also have a few, Dr. Eddy, the next slide, please. We also have a few polling questions. So with regard to poll, what I would say is as soon as it's launched, we'll give you a time of like 30 seconds to go through the poll, and then you can put in your answers appropriately. And at the end, once the poll results are announced, you kindly close the poll slide so that you can again get back to viewing the presenter slides. And just a last minute, just a disclaimer. Please note that the information presented in this presentation is intended for educational purposes only, and this is not meant to be a substitute for professional medical advice, diagnosis, or treatment. And this information may not be applicable to all individuals or situations. So before I hand over this online podium to our esteemed speakers, I just want to quickly share 2 slides with you and probably 1 poll question. I believe, like what I see, like around now it's almost now 200 participants. I believe all of you are like pediatric surgeons, pediatric anesthesiologists, or pediatricians here. It's a niche group of audience. So we all cater to an extremely special, vulnerable group of children. And so I just want all of you to take like 15 seconds to reflect on what vulnerability means. So because I personally feel that children in many aspects, especially when it comes to pain assessment, prevention, and treatment, they depend on adults and us physicians to make valid decisions for them. Yeah, the next slide. So this takes me to my next slide. And I'm sure as doctors, we have all had those times when we had to make tough decisions. It could be, especially when it comes to treating vulnerable population. So I think these 4 principles of medical ethics should constantly remind us to whether we are doing right or not. Basically, the non-maleficence, autonomy, beneficence, and justice. But I also feel that, when it comes to children, probably we trespass in some of the boundaries, especially the autonomy and the non-maleficence part. So this actually takes me to the next slide. Dr. Eddie, can you please share? Yeah. So I call this the modified rock test, and I ask all my juniors, or it could be pediatric surgery residents or pediatric anesthesia residents. So I tell them, like, before you treat a child, ask yourself one question. Like, if it is Dwayne Johnson, would you do or say the same things you do to a child? Would you do that to Dwayne Johnson? Like just seriously think about it. If it's like, like pinning Dwayne Johnson and putting forehead lacerations, or like doing an LP without consent, I don't think we would do this on Dwayne Johnson. So this is my poll question to all of you. So do you treat all children like you would treat Dwayne Johnson? So I'm just going to share this poll. Yep. Can you see it? You can go ahead and answer, and I'll just give you 30 seconds to obviously answer. And this is not going to be judgmental. This is just for us to reflect on what we are actually doing. And yeah, the poll has ended, and the results are, like, I see, like, majority, like 62% have answered no. This is not meant to be a judgmental question at all. So it's just something that we need to think about. And yeah, thank you for answering this poll question. I'll just get back to introducing my amazing group of all women panel of speakers that we have. So our first speaker is Dr. Reline, who's, I mean, it gives me great pride to announce that, like, she's the first DM pediatric anesthesia anesthesiologist for the entire country. She's currently heading the pediatric anesthesia department at St. GS Medical College and King Edward Memorial Hospital. And she's also, her areas of interest are pediatric neonatal anesthesia, critical care, cardiac anesthesia, and acute and chronic pain services. Dr. Dias, I hand over the online podium to you.
Thanks, Anu, so much. So hi, everybody. Namaste. And I bring you greetings from Mumbai, India. I have a few poll questions before we start off. Can we see the first question, please? Yeah. So this is the first question. Flack best suits which child? So would you go with Arav, who's 6 months, or would you go with Dev, who's 8 years? So you have 30 seconds to answer. Can we see the results, please? Yeah, so most of you are correct. Arav is the right answer. And we will see in my slides later why it's the correct answer. So can we see the second question, please? Which factor does not increase the risk of developing chronic pain? Is it nerve damage, use of preventive analgesia, psychological vulnerability, or is it the severity of pain? Can we see the results, please? Yeah, so we have a very well-informed audience, and thank you for that. We'll now move on to my talk.
Hi, so I'm going to just run you through an introduction to perioperative pain management in children. I bring you warm greetings from St. J.S. Medical College and King Edward Memorial Hospital, where I practice. And this year we celebrated 97 years of the foundation of the institute. So I have nothing to declare. And by the end of my talk, you should be able to identify the types of perioperative pain in children, describe the neurophysiology and adverse effects in kids. You should know how to assess perioperative pain in children. And we will see principles and strategies of pain management and how to prevent the progression from acute to chronic pain. So when I looked up literature, I found over a period of, the last 10 years from this study, a US study of 2012 published in Pediatric Anesthesia, which reported a 44% prevalence of perioperative pain in children, right through 2020, the South African study. The incidence hasn't changed much. It is still around 30 to 40%, which is quite high. And this is irrespective of whether analgesic drugs were prescribed, whether or not they were going around the clock, or whether these kids were given everything properly. Irrespective of all that, 40% of children were still suffering in pain, which means what we're doing is not adequate and we have to do more. And this was published in the Lancet Child and Adolescent Health Commission in 2020. And if you look at this picture, it's a beautiful picture, which takes you through all the kinds of pain that a child or a pediatric patient would experience right from the neonatal age group up to adolescence. And if you look here, you will see that at some point in time, most children will have some kind of pain associated with surgery. So let us see what are the types of perioperative pain. So you can have a procedural pain, which is mostly because of the intervention. In this case, it's surgery. And here we know that the duration is predictable. You know for each surgery and for a specific surgeon for how long the pain is going to last. And you also know that it's going to cause anxiety and distress post-operatively. On the other hand, you have the post-operative pain, which is frequently due to trauma of surgical incision, but you have to remember that this pain could be due to other aspects like positioning. Let's say if you're giving a prone position or a lateral position with the head high. So, that can cause a pain all over, Also referred shoulder pain, for example, in a laparoscopy. So you may not have pain at the site of surgery, but you may have it somewhere else. And again, there may be simultaneous interventions like, let's say you have intubated the child and now the child is having a sore throat post-operatively. And so here again, we know that this duration is predictable. You know for how long this pain is going to last. And you know that your pain management is fundamental here to the recovery of the child. So from the landmark paper by Anand et al. Way back in 1987, we all know now that pain thresholds increase with age, and neonates and children, they respond more easily to pain than adults. So infants have lower nociception thresholds and therefore they respond to lower intensity stimuli. And this is because of all of these things. So, there are inhibitory signals which are present in the adult circuitry. You can see this minus mark here. And these are responsible for suppressing or dampening noxious inputs. So these are poorly developed in neonates and in infants. You can see here there are no inhibitory signals. On the other hand, look at the nociceptor receptor fields. So this orange one are your nociceptor signal fields and the green one are your tactile or your proprioception fields. And look at them in adults, they are well separated. But if you look at them in neonates, there is a lot of overlapping of fibers, and therefore even tactile inputs can be interpreted as a painful stimulus. On the other hand, nociceptor fiber composition is different. So your low threshold A fibers are dominant at birth, which are slowly replaced by your high threshold C fibers. And these A fibers are mostly responsible for your gate theory modulation and your spinal interneuron level modulation. So when we talk of the sensitization theory of pain, we need to understand that this is a normal pain threshold. So this is something that would, an intensity here would normally incite pain. And this is the intensity of response. So here, this is a sigmoid shaped graph, and this is what you would see then normally. On the other hand, if you look here, this threshold gets reduced and it now gets moved to the left. So here, even a stimulus which is not otherwise painful is now inciting pain, and that is called allodynia. And this is a function of central sensitization, which happens mostly at the brain level and the spinal cord level because of your A delta fibers and your interneurons. Now, the intensity of the response also may increase, and this is called hyperalgesia. Now, all of this is because the receptors or the nociceptors are getting sensitized, and there is an increase in the inflammatory response. There is an upregulation of receptors at the peripheral level. So this is your peripheral sensitization, which is responsible for your primary hyperalgesia, which is the hyperalgesia or the increased intensity at the site of injury. On the other hand, you also get something called secondary hyperalgesia, which is an increased intensity around the site of injury, and that is because of central sensitization. So if you've understood all of this, we know now that excessive acute pain at key windows during infancy and childhood can alter response to subsequent pain later in life because of the nervous system plasticity. And this is because nociceptor development and maturation is incomplete. Pain thresholds may be increased or decreased later in life, and inadequately treated perioperative pain is a precursor for chronic pain. And therefore, it is very, very, very important for us to adequately treat perioperative pain to prevent this progression. So who are the children who are at high risk? Those who have a genetic predisposition, those who are already extremely anxious, those who have had prior unpleasant experiences, and those children who are in chronic pain. Now, when we assess perioperative pain, it's important to identify a validated tool, and you select a proper tool for that child, for his age, as well as his cognitive ability. So children who are having communication difficulties like autism, or children who are cognitively impaired, there are specific tools available for them. And in these children, it is very important to encourage and support and include the parents in assessing pain with their child. So the parent of these children, they are the best people to tell you what is an abnormal behavior in their child and what could possibly be pain, because these children will not be able to tell you accurately. And unless you are trained and you have done sufficient number of these kids, you will not be able to assess it either. So you need the parents here. And in certain situations, you may also need an expert like an occupational therapist who has dealt with these kind of children and who knows how to assess pain in them. So every institute should implement a protocol for assessment and for management of pain, and you should have a plan A and a contingency plan B in case that plan A fails. And for every, for different kind of surgeries, you should set up your own protocol. So there are three main modalities when we assess perioperative pain. The first are the self-report measures. Now, this is the gold standard and it should be used whenever possible. But it's not possible to use it in all, across all age groups, because you need a cognitively prepared child for this. So in 3 to 5 year olds or in toddlers, you may not be able to use these measures, but you can use the observational measures there and with a simple yes/no question. Observational measures are usually, you look at the behavior of the child, you look at the vocalization, the facial expression, you look at the bodily movements, like if they are, in a flexed posture, and they seem to be in distress. And these can be used in children less than 4 years, so in the toddlers, in your preschool children, in children having learning difficulty as well. And physiological changes can be used intraoperatively. So we use the analgesia nociceptive index or the neonatal infant pain evaluation. And they have been reported to, quite adequately correlate with pain scores. So these are the tools that are available. And, as you move towards the right, you can see Comfort B and FLAC. These are used, these are more of observational scales or the behavioral scales. And then as you move here down, you have the self-report measures, which are used in the older children. But have you ever thought, what is the problem with these scales? So how do you know where it's paining or where does it hurt? And can anybody identify this scale? So most of you may be familiar with this. This is the Wong-Baker facial pain rating scale. And, Connie Baker, way back in the 1980s, she realized later that there was something wrong with this scale and she needed to fine tune it. So she fine tuned her own scale. And what she did was she went to the bedside of these children and she just drew pictures of a child and she asked them to point out where it hurts. And she noticed that these children were accurately able to point out exactly where it was hurting them. And then she told them that, let's say they said it hurts here. Then she told them, now you tell me on this scale, how much does it pain? And see here, he has labeled this as 5, it's killing me. Or he has labeled this as 2, it's not hurting me now. So that's what she did. And you can use the simple thing, just draw a picture and ask the child. Or today we have apps, there is an app for everything. So you can download these apps. This is the Improving Palliative Care for the World's Children app. And you can see here, you can choose your avatar and then they're asking Suzanne, where is the pain? So Suzanne points out. And then, children love these mobile devices. Or then you can ask them to just point out, how badly it's hurting. So always anticipate and prevent perioperative pain as far as possible. And we have various strategies like pharmacological, which include opioids and the non-opioids, regional blocks, the non-pharmacological like psychological and the physical methods. So non-pharmacological in neonates usually includes swaddling, breastfeeding, non-nutritive sucking, or kangaroo care. Pharmacological can include sucrose, and it reduces stress and pain behavior for brief procedures, and it's more effective if you combine it with the other strategies like non-nutritive sucking. So pharmacological in older children include your local anesthetics or novel methods of drug delivery like transmucosal, opioids, non-opioids, your PCA pumps, and your elastomeric pumps for your regional blocks. The non-pharmacological can include anything right from hypnotherapy to TENS to physical entities. When we talk about the various types of analgesia, we all know what is preemptive analgesia. So this is your duration of surgery. And this is the nociceptor input intraoperatively, and this is postoperatively. And this is the hypersensitivity that develops. Now, if you're going to give your analgesic before the surgery, which is your preemptive analgesia, you can see here that the nociceptor input is completely absent intraoperatively, but postoperatively, there is some amount of response, but it is less. And if you look at hypersensitivity, it doesn't develop at all intraoperatively, but it is there post-op, but again, it's less. So on the other hand, what is preventive analgesia? So if you look here, you're giving your preemptive analgesia before your incision. There is no response during surgery, and you're also giving analgesics postoperatively. So this is decreasing your nociceptor input postoperatively. And if you noticed here, there is no hypersensitivity that develops at all. Okay, so preventive analgesia is actually the best thing that you can do. You give it preemptively, plus multimodal, which is during as well as after surgery. And all of that will help to prevent your progression from acute to chronic pain. So this is the prospect study, which was published somewhere in 2017 and was done by a collaboration of both anesthetists and surgeons, and they gave evidence-based recommendations for each kind of surgery. So this is procedure-specific postoperative pain management prospect. And like, for example, you can just take pain in a adenotonsillectomy, and then they give you the first line, which is paracetamol plus an NSAID plus dexamethasone. And if you have to move on to a second line, then you can use any of these drugs. So that's it actually from me. And I have some suggested further reading. You can go through the Association of Pediatric Anesthetists of Great Britain and Ireland. These are their pain guidelines published in 2012. It's a beautiful article, and I haven't found anything after that by this association. The Australian and New Zealand College of Anesthetists have their evidence-based guidelines, which were published in 2015. And this is the Lancet publication, which I spoke about earlier. And, they have a 4-point management. So you have to make pain matter, you make it understood, you make it visible, and that helps in making pain better. So it's all based on collaboration. Again, the solution for kids in pain, the SKIP initiative, it's a Canadian initiative, and this is also based on, coordination and collaboration. And finally, you have the Sick Kids paid modules, which are available online. It's available free of cost. So the best things in life are free. You get a certificate on completion of each module, and knowledge only increases when it is shared. So I would encourage each of you to go through each of these modules. There are around 8 to 9 modules, and it will really help you to change your practice. So that's it from me. Thank you. And I would be happy to take any questions later at the end of all the 4 lectures, or you can email me on this address.
Dr. Aleem, thank you so much for the superb high-level overview on pediatric pain management. So our next topic is use of opioids and non-opioids for pediatric pain management by Dr. Nai's son. I had this privilege of meeting Dr. Nai's son while pursuing my fellowship in pediatric pain. She's a staff anesthesiologist at the Hospital for Sick Children, Toronto. Dr. Sun completed her medical training at Stanford University. She also obtained her anesthesia residency and pediatric anesthesia fellowship training at Stanford. Her clinical focus is on management of chronic and transitional pain in children. Also, Dr. Nai is the co-lead for Pediatric Pain Echo. These basically provide virtual clinics which are focused on improving acute and chronic pain management. And I would say it's an amazing resource. I do try to log into the Pain Echo, but the timings don't actually match. But otherwise, you can always go back and see the recorded sessions. Her focus includes safe use of opioids for pain treatment, transition of acute to chronic pain, and use of opioids for pain treatment in children. Dr. Nai, I'd like to hand over this online stage to you. And thank you for being with us at this extremely odd hour. Probably it's 5 a.m. in Toronto now. Thank you so much for being with us.
Thank you so much, Anu, for that introduction. I am just going to start sharing my slides. So give me 1 second. Anu, do you mind just confirming if you can see my slides okay?
Yes, Dr. Nai, I can see your slides.
Okay,
You're audible.
Perfect. Thank you so much. So good evening, everyone. As Anu said, it's about 5:20 in Toronto time. So good morning for the North American people joining. So I'm really honored to be invited to be part of this webinar series. As Anu said, I'm a pediatric anesthesiologist and chronic pain physician at the Hospital for Sick Children, which is affiliated with University of Toronto. Let me just move my slides. So I just want to show a photo of where I work and live. Here are some photos of Toronto. We've had a really cold and long winter, so that's why I'm showing some winter pictures, but we're starting spring this past 2 weeks, so very excited. And also pictures of Hospital for Sick Children, or Sick Kids, as locals call it. So as you see, this right is the Hospital for Sick Kids, which is about a 450-bed tertiary referral hospital and the largest children's hospital in Canada. So some learning objectives for today. I've been asked to talk about some principles of multimodal pain management, to summarize the evidence about commonly used analgesics in children and adolescents, and also to be able to apply evidence to prevent and manage surgical pain in children more effectively. So first, as Dr. Diaz said in the earlier talk, up to 40% of hospitalized children experience moderate to severe postoperative pain. Once the severe pain starts, it tends to last for many days. Some consequence of inadequately treated pain includes poor sleep, change in mood and anxiety, increased incidence of chronic post-surgical pain. As anesthesiologists, one of the most important things we can do to treat these patients is to provide multimodal or a balanced analgesic approach whenever possible. And that means combining different drugs from different mechanisms of action with the goal of providing better pain control with less side effects than relying on a single drug. Pain medications, you can see, work on many different levels of the pain pathway. It should always try to include different medications that work on different areas, such as acetaminophen, NSAIDs, ketamine, local anesthetics, biregional block or infiltration, and gabapentinoids. These are just some of the drugs that we can use for multimodal pain treatment. As you can see, acetaminophen and NSAIDs tend to work more on the periphery, while opioids work on the spine, the brain pathway. The medication we choose should be surgery specific with different options and then tailor it to the individual patients. These non-opioid medications are the cornerstone to build a successful multimodal analgesic regimen, and we should try to optimize these whenever possible. There are few guidelines to help anesthesiologists for pediatric pain management. The oldest and the most commonly used is the WHO pain ladder, which has been around for a long time. It was initially developed for managing cancer pain, but has been adapted over the years also for chronic non-cancer pain and acute pain. So at the base, you have mild pain for acetaminophen and anti-inflammatories, and then you add opioids for moderate to severe pain. Adjuvants can be added at different levels as well. For acute pain, such as after surgery, we tend to reverse the strategy. So you start with your strongest analgesic for when the pain is the highest right after surgery, and then de-escalate quickly as the pain improves. The WHO also provides some guidelines around dosing. They recommend oral dosing whenever possible, as it's less invasive and you get a more steady level. So you get less of the peak and the troughs as compared to IV boluses. And also to do around the clock administration rather than as needed, because if you're just giving it when the patient is having a lot of pain, you tend to get behind and the pain escalates sometimes further. You want to prescribe the analgesics according to pain intensity. So pain needs to be assessed regularly using age-appropriate tools, as Dr. Diaz said, and provide individualized therapy addressing the concerns of the patient. So there's no standardized dosages in the treatment, and the type and the dosage needs to be continuously adapted to that individual's patient's pain needs. Here are a few recently published guidelines. I won't go into them in too much detail, but these are interesting reads if you have time. The top one is from the Society of Pediatric Anesthesia, created by a group of anesthesiologists, while the bottom one is a US guideline published in JAMA Surgery by a group in LA. It's a little bit more controversial in the pain community, as they really advocate for opioid-free analgesics for a few procedures. The last is the ASPA pain management ladder, which provides some suggested basic, intermediate, and advanced pain management options for different surgical procedures, and it's quite practical. Next, I want to go through some evidence for some of the common analgesics that we use perioperatively. Multiple studies have found that even a single preoperative or intraoperative dose of acetaminophen or paracetamol decreases postoperative pain and opioid consumption for a variety of surgical procedures. This one is an RCT published in JAMA that shows babies undergoing major thoracic and abdominal surgery randomized to IV paracetamol versus morphine continuous infusion. So the paracetamol group received 66% less morphine compared to the IV morphine group. And this was quite impressive, the amount of improvement that you can see. And so for all patients without contraindications, I think we should offer acetaminophen and paracetamol. In my practice, all patients are offered a dose of oral acetaminophen in the preoperative area before surgery. NSAIDs also have a very important role in pain management. A systematic review on NSAIDs, and unfortunately we don't have anything more recent, this is from 2012, for postoperative pain shows that NSAIDs can decrease postoperative opioid consumption in the first 24 hours and also decrease postoperative nausea and vomiting. Oftentimes, our surgeons are hesitant to use NSAIDs due to concerns about bleeding. And I think all surgeons are similar in different countries. So we now have several studies as well as large meta-analysis. This one with 18 different pediatric studies, including 1,700 patients, showing that NSAIDs are not associated with an increased risk of bleeding or readmission after tonsillectomy surgery. And there's other studies that shows it for orthopedic and general surgery procedures as well. I won't go into this one in too much detail, but this slide shows some commonly recommended doses of acetaminophen and commonly used NSAIDs. And as we talked about earlier in the WHO pain ladder, opioids are a very important part of treatment for moderate to severe pain. However, there are large inequality in the availability of opioids around the world. I was really surprised to read this, but it's estimated that over 75% of the global population have low to non-existent access to opioid analgesics, while in Europe and North America, which contains only 17% of the world's population, consumes 89% of the world's supply of morphine. This was shocking to me. So while there's an opioid epidemic occurring in North America, in many parts of the world, it's hard to access opioids to treat conditions like post-surgical and cancer pain. There's also differences in which opioids are most accessible in each country. For example, morphine is the most studied opioids among children and most widely used in my institution, but I know at other hospitals, different ones are more available or preferred. So in children, we do need to be cognizant of some differences in specific opioids. In particular, codeine is a prodrug that requires metabolism for it to have its analgesic effect. It needs to be metabolized by the hepatic enzyme CYP2D6 to morphine for it to have any analgesic effect. And there's a lot of genetic variations among the population, which leads to variability in its effect. So in a group that is a poor metabolizer, they may have little or no analgesic effect, while people that are ultra metabolizers, they metabolize the codeine to morphine very quickly and they have to get very high levels. They can have high risk of adverse effects like respiratory depression and potential death. So there's definitely little concerns about using codeine in very small children. Tramadol also requires metabolism by the same enzyme, but not quite to the same extent in the variability. So it just needs to be used cautiously in patients with respiratory risk factors such as obesity, obstructive sleep apnea, and severe lung disease. PCA is another great tool that we have to treat moderate to severe pain. So postoperative opioid PCAs allow for more stable levels of analgesia using small boluses that the patient can deliver and control themselves. And there's studies to show that it can be used in children as young as 5 to 6 years old if they have a good understanding of the principles and appropriate monitoring is available. It allows the patients and the kids to have a sense of control over their pain. They're very useful for major surgeries. And in adults, it's been associated with higher patient satisfaction when compared to intermittent IV boluses. And there's less evidence in children, and there's no evidence for use of one specific opioids over another. In my practice, we typically start with morphine and rotate to hydromorphone if the patient have too many side effects or their pain level continues to be high. One of the controversies regarding pediatric PCA is whether a background infusion is indicated, and the data is conflicting. So it's really up to your preference, but with or without a background infusion, it's important to have appropriate respiratory monitoring available for these kids, such as regular check of respiratory rate and pulse oximetry. Some common uses that we use it for include post-scoliosis repair for kids who have severe chemo-induced mucositis where they cannot take any oral intake, and also for patients of acute sickle cell crisis where the pain comes on very quickly and is very high. And here are some common opioid-related side effects that are encountered. For example, with patient can have severe pruritus, nausea, vomiting. They can have constipation, sedation. Just to give an example, for pruritus, commonly we start with treating with antihistamines such as cetirizine as a first line. If this itching is still present, we try opioid rotation to a different opioid that may have less of the side effect. And as a third line, there are studies that show that low dose naloxone between 0.25 to 1 mic per kilo per hour are very useful for opioid-related pruritus and vomiting, and they're not associated with any change in pain level or total opioid use. There are some other great medication that we have available to create a multimodal pain regimen. Ketamine may be very useful for children undergoing surgery where there's a high risk of neuropathic pain, such as amputation, or in kids who are opioid tolerant, who may be on chronic opioids for severe chronic cancer pain. So in low doses, the ketamine have mostly analgesic effect. In higher doses, you may get into more of the psychomimetic effects, such as vivid dreams or hallucinations. So when we use intraoperatively, we tend to use low doses, and it can decrease PACU pain scores and analgesic need postoperatively. But the effect seems to be short lasting, mainly in the first couple of hours after surgery, looking at the data. And it's also associated with low incidence of postoperative nausea, vomiting. It can also be used postoperatively for neuropathic pain or pain where opioids are inadequate. We typically use infusion rates of 2 to 4 mics per kilo per minute, and dose-limiting side effects tend to be dizziness or sedation. And dexmedetomidine is a newer drug that's really great. It's a central alpha agonist that's becoming more and more available. So at higher doses, higher than 0.5 mics per kilo, you get to see more of the decrease in postoperative pain improvement and also opioid consumption decrease. The bonus, it also decreases emergence delirium and PONV. The downside is your patient may be more sedated and require a longer PACU stay. You can also be added to local anesthetics as an adjunct for peripheral block to make it last longer. So we're really finding more and more uses for dexmedetomidine perioperatively. Lastly, there are a few studies on the use of gabapentin. It's a chronic pain drug used for, it started as an anti-seizure medication, and it still has some conflicting results. The first study is a study done by some of my colleagues. Gabapentin was given as a single dose prior to scoliosis surgery, and there was no difference found on pain or opioid use. However, the lower study, where the gabapentin was given preoperatively, and then for 5 days following surgery, the total morphine dose was lower and the pain score was lower in the PACU as well as postoperative day 1. So we really need more studies to see what's the optimal dose and duration of treatment. However, pediatric RCTs are very difficult to do. So in my practice, we use gabapentin for very painful procedures such as spinal fusion or NUS procedure. It tends to be started 2 to 3 days before surgery and then continue during the hospitalization and wean at the time of discharge. Lastly, it's important to acknowledge that medication is just one prong of a multidisciplinary pain treatment plan. We should also always add non-pharmacological treatment like ice, heat, positioning, distracting, breathing techniques whenever possible, as they're very safe, they're easily available, and they may reduce the need for analgesic medications, which have side effects. So in summary, moderate to severe pain after surgery is very common in children. And as anesthesiologists, multimodal analgesics are the simplest and most effective method by which we're able to improve pain in children postoperatively. And remember that pharmacological treatment is just one prong of the total multi-D pain treatment plan. Here are some references for my talk. And thank you so much for inviting me to be part of this and listening to me. Thank you. I'm going to stop sharing now.
Dr. Nai, thank you so much for that extremely lucid and clear talk on pharmacological management and pediatric pain. So actually, we have quite a lot of questions coming up in the question and answer. So just go ahead. I mean, we all can discuss it, but as it mostly concerns multimodal, so just feel free and go ahead and answer them. Meanwhile, I'll go ahead and introduce our next speaker. This is Dr. Bhagya, with whom I have the privilege of working on a day-to-day basis. She's a young, passionate pediatric anesthesiologist, and I would like to say that she has magic in her fingers when it comes to ultrasound and regional anesthesia. She's going to be talking to us today about regional anesthesia and the role of regional anesthesia in pediatric postoperative pain management. Bhagya, the stage is all yours. We can see your slides, Bhagya. Unmute yourself, please.
Okay. Am I visible now? Hello, ma'am.
Yeah, yes, Bhagya, we can hear you and your slides are also seen.
Yeah. Hi, everyone. I'm Dr. Bhagya. I'm from Indira Gandhi Institute of Child Health. And my topic of discussion for today is perioperative pain management with regional anesthesia. Honestly, when I got this topic, hello, ma'am.
Bhagya, are you having trouble with your slides?
Yeah. It's not working.
I'm happy to share. I'll do it. Just give me a minute. Just give me a minute.
Yeah. Just a second.
Do let me know. Oh, okay.
Yeah, it's coming. It's coming. Sorry for the interruption.
No worries.
Honestly, when this topic was given to me, this was my first feeling. Why would we discuss regional anesthesia again? With so much of vast data and so many seminars going on again, regional anesthesia. And recently I looked through some of the videos. ASPA conducted a elaborated 5 hours of video on this. So when I looked through all the videos with Academy Awards going on and recently, I thought how much to cover and what to cover. I've tried my best to go through this, but when regional anesthesia techniques in perioperative period as a topic cannot be ignored, because in acute pain, this takes the first place. So there's no way this topic can be ignored and it needs to be discussed in detail. With a traditional slide at first, we all know August Bayer was the first person who introduced. There was a period when regional anesthesia took a backseat. General anesthesia became more popular because of a lot of advances. And recently, because of the neurodevelopmental issues, regional anesthesia is coming back again. Another traditional slide, we all know children are different in all perspectives, be it anatomical, physiological, pharmacological, and psychological. With regional anesthesia, there is a lot of advantages. We all know, apart from being pain relief technique, there are other advantages too for its use in perioperative care. Today's topic, I have just focused on these 2 topics, mainly the elementary issues, which I considered as the basic issues, which often we think we know, and these are the things which we often forget first. Secondly, in this busy practice, we often forget to update ourselves with many evidence-based updates. So I would be just focusing on few elemental issues and few evidence-based issues. Hope it's of some use. To begin, I have selected a few elemental issues. I'll go through this one by one. Recently, in 2015, the European and American Society collaborated with a beautiful review article which focused primarily on what are the controversies which are there in regional anesthesia. I look through one by one. The first important controversy which was known was, should we practice pediatric regional anesthesia in a child who is sedated or under GA? Kindly note there are more than 4 large-scale studies done, and this topic doesn't have any controversy anymore. The doubts are cleared. Practicing regional anesthesia in a sedated child is the standard of care and should be accepted. The second controversy, which was most important, was what about this test dose, especially when we are giving the epidural analgesia? A lot of people still have doubts regarding this, and it's still a huge disparity. There are some people which practice this. Honestly speaking, in our institute, we don't practice using test dose. But still, having a look through continuously when we are injecting the drug and intermittently aspirating it does benefit. But what is important for us to notice, often whenever we giving a test dose, we look through the heart rate. Heart rate is a pretty later sign which is seen. So it's a better practice if we look through T-wave amplitude in younger children and a depression in older children, which is a better sign. The third important controversy was what to use for the loss of resistance technique, air or saline. Few of our colleagues came up with another compromised technique where they used saline with 0.5 ml of one air bubble inside the syringe. And they did get a lot of good results and safety profile. But what matters here is whether we use air or saline, what matters is the volume. Even if we use a high volume of normal saline, it doesn't benefit. It will dilute the drug. So it's the volume that matters. The fourth important controversy is compartment syndrome, especially in orthopedic procedures. We would have seen in most of the orthopedicians are also very concerned when we are giving epidurals. I believe that the way success is a teamwork, we have to take certain responsibilities with side effects as well. Maybe epidural does not directly cause any compartment syndrome or may not delay, but definitely because of the deficiencies in the system, this compartment syndrome is getting ignored. So what is important is we need to educate the staff, identify the risk children, and whenever in doubt, let's do some serial examinations and go ahead with pressure monitoring. Another elemental issue, which is actually truth, is the neurotoxicity of local anesthetics. As much as a local anesthetic has its anesthetic potency, it is also neurotoxic. And there are many mechanisms by which a local anesthetic drug causes the neurotoxicity, which we cannot ignore in a concentration-dependent manner. What is important is the killing potency of each individual drug. Various studies have been done, and it is proved that bupivacaine is the most neurotoxic drug. But the irony is, when a lot of drugs were stopped in practice, like lignocaine, bupivacaine is one drug which has not caused much of transient neurological deficit. Most of the literature is still not available regarding the neurotoxic effects of bupivacaine, but the lab studies say that it does have a highest killing potential. The other elemental issue which we ignore is risk of infection. Still in this topic, chlorhexidine rules the armatorium. We in our institution, honestly, we use povidone iodine. But with two important concerns, this is also beneficial. But what we need to know is, once we put the povidone iodine, we should give adequate time for it to dry. And once we finish the procedure, we should properly clean and start the procedure. So even povidone iodine is also a good choice. But overall infection caused because of regional anesthesia with infection is very, very low. The most common elemental issue still ignored is consent issues. We have a proper consent format for surgery. We have proper consent format for general anesthesia, but for exclusive regional anesthesia, we still do not have. So recently in 2022, there has been a guidelines which has been issued both by the European and American society. They have beautifully made all the guidelines step by step. Maybe at the institutional level as well as in each consultant level, tips can be taken from these, and a institute can prepare a separate consent for regional anesthesia, which would be beneficial and definitely in safety. With all the elemental issues going on, often we doubt whether we should practice with regional anesthesia or shall we finish up the case with general anesthesia. I believe, like the Denny said, a right dose of right drug at the right place always definitely provides benefit. And I believe it's for the right patient should be chosen. Just a broad view, a few points. We all know the broad classification, how the regional anesthesia has been divided and further subdivisions. I'll not delve into detail of each one. Just a few points of relevance. Caudal is still quite popular. One of the issues with caudal which we often discuss is, should we give caudal before the surgery or after the surgery? Preemptive caudal analgesia is also beneficial and post-operative is also beneficial. There are some studies who have done giving both before and after surgery, definitely keeping into mind the toxic dose. But what is important for us is any surgery which can progress more than 3 to 4 hours, we can do this, giving it twice. But there are no definite sure shot studies telling one is preferred over the other. One more important thing is, I also believe that more than the indications, the contraindications are more important in any technique. This is one common sign which we see whenever we practice for caudal analgesia, sacral dimples. And recently I found an interesting article by Marsarella in 2021, who very nicely defined how we can go ahead whenever we visualize a sacral dimple, how we can choose whether to go ahead with the regional or to withhold. They identified high risk group. Whenever there is a sacral dimple, which is more than 5 millimeters, more than 2.5 centimeters from the anus, and multiple with the nevus, with the hair, then it's better to avoid. But I often believe that if anybody is in doubt, wants to go ahead with a further investigation and assessment, kindly go ahead and abandon the procedure if you want to. But there are some guidelines and protocols and studies which will definitely be beneficial. Some pearls in caudal. Caudal is a volume dependent technique, and often we use 0.2%, but 0.175% is also a very good choice. Various doses are available in textbooks with a wide range, but I found this interesting article in 2018 by both the societies, who have given a very easy format to remember the drugs both for single shot as well as continuous infusion. I won't get into the details of these infusion details. You can look through it. It is very simple and nice. But what is very important is the toxic dose. Toxic doses should never be overcome, especially in pediatrics. With respect to adjuvant, this is a very important point, that apart from clonidine and preservative-free morphine, not many drugs are registered. But there are a lot of studies which are done on various adjuvants. Many studies, many people in institutional level have done studies on all the adjuvants. But I would say, look through all the large-scale studies, protocol-based studies, and then start practice with adjuvants. Spinal anesthesia, I think it's one of those techniques which never wears off as far as anesthesiologist is concerned. So it is coming back, and it is still popular with preterm, premature children. But one point I want to, just as a pearl to add, often even in our institute, whenever we look through any teenage child who comes after 12 to 15 years, we think that let's finish up the case if it's an infraumbilical surgery with spinal. But please note, the PDPH incidence in this teenage group is very high. It's around 10 to 50%, very, very high. And there are many mechanisms by which this PDPH can occur. And the treatment is pretty simple. A bed rest, good fluids, and a simple analgesics can help. But keeping in mind the high incidence of PDPH definitely helps. Peripheral nerve blocks have always been one of my interesting topics. And whenever I look through this topic, I feel it looks like stargazing. You know, we visualize the starting with the zodiac signs, the stars, galaxies, everything. And at particular point, we start seeing that there are more number of stars. We start naming them with numbers, alphabets. That is when we get into the reality of peripheral nerve blocks. It is just an impossible reality. I just started to note down the names of these peripheral nerve blocks, starting from the head and neck blocks, going ahead with upper limb blocks, lower limb blocks. This is where I ended, and I realized the blocks have been very, very, very huge. And I was in no way going to start with each block, how it is given, indication, contraindication, and the details of which. There are a lot of internet data available, videos available in YouTube regarding each block. And every day a new block keeps getting added. Maybe after this seminar tomorrow, we might even end up with a new block in the scale. But there are some relevant important points with peripheral nerve blocks. This dosage guideline is definitely from the American and the European Consensus Society. In a simple way to remember, it's very easy, both for infusion as well as single injection. One more article I recently read in 2022. So people have been using adjuvants, single adjuvants. One of these studies, they have started using more than one adjuvants. They even combined buprenorphine, dexmedetomidine, clonidine, dexamethasone, and many people are coming to just prolong the analgesia period with more and more techniques. But what we need to remember here is most of it are off-label issues. As such, in pediatric practice of analgesia, we don't have a proper registered drug. So before jumping into all these techniques, it's better to go it in a very safe manner. As I said, the peripheral nerve blocks have become so huge in number that the American and European Society realized that we needed to standardize the nomenclature. So they came with a standardizing nomenclature technique way. They've started with abdominal wall, paraspinal, and chest wall blocks. It's a nice article you can look through. What benefits are there is a strong consensus, and color coding they've started. If it is in the blue color, there is a strong consensus, and like in a pink color, it's a weak consensus. So we can go ahead which to practice in a more safe and better way. No technique is devoid of any risks. Regional anesthesia also has risks. I have just highlighted these three common available risks, which have a few updates and recently. There's been review article interesting in Canadian Journal where they saw all the blocks which can cause bleeding. And they found out that in the summary, these 4 blocks have the highest incidence of providing bleeding incidences. But what is important is all the data that is available are level 3 or 4 data. So it is very, very low evidence. So it can be still practiced very safely, irrespective of the bleeding incidence. The other complication is the local anesthetic systemic toxicity, which we all know very well, and we all know how to manage it as well. But the one important controversy that is existing with intralipids is there is two school of thought. There is one school of thought who say resuscitation is very important. The other school who says intralipid should be given first. Why resuscitation should be done first is there is a lot of intralipid problems arising. There is pancreatitis, fat embolism. The other school who say intralipid first, what they believe is whenever there is resuscitation, there is an acidosis chance. So because of which the affinity of the intralipids towards the local anesthetic might reduce. But irrespective of this controversy and two school of thought, we still don't have a clear-cut guideline on this. Ultimately, everything ends up to our famous line risk-benefit ratio. So looking at through the patient's condition, we can decide what to do. Even this thing has crossed my mind. Should we use propofol instead of intralipid? But truly, please don't try using propofol. It can cause more damage rather than beneficial. And anybody now, if they require a guideline, there is a separate website itself created for intralipid and its use. Ultrasound has been a muse. It always appears to me like a new sunrise. Every day a new hope arrives and something new always comes in ultrasound. We all know that ultrasound has a lot of positive qualities. Benefits of ultrasound is quite popular. Everybody knows. But what we don't realize is ultrasound also has complications. Many students have done a lot of complications which is directly related to the training experience. Even now, when we teach a lot of students, many basics are forgotten. For example, just looking at the tip of a needle while giving a block, ergonomics, failure to just identify whether the drug is in the muscle or in the fascia. These common, simple things do contribute to the failure of the technique as well. And so what is the necessity of this R is a learner-centric based curriculum. One more thing we often forget is ultrasound itself is also a technology. It does have its own limitation. For example, when you say how a nerve is visualized inside ultrasound, we call it as an hyperechoic structure. But whenever a nerve is in a deeper structures, yes, it is hyperechoic. And we all know when we visualize the nerve in interscalene, it almost appears like a anechoic structure, easy to confuse with any blood vessel. And this is not the problem of experience or anything. It is the limitation of the technology itself. So ultrasound itself also has its own disadvantages, which we need to know prior to popularly practicing it. So this was a review article in which they spoke about and nicely categorized how the ultrasound side effects can occur in technical and non-technical groups. But what is important is, yes, everything can have its side effects. But even the authors of this article, they gave the title of this article as Keep Moving Forward. So we need to do an evidence-based integration of ultrasound technology and practice it. Another important thing is, should we use a nerve stimulator? In pediatrics, the nerve size is small. Yes, there are certain disadvantages. But in many cases, for example, a cerebral palsy child or an AMC child, the benefits of nerve stimulator along with other techniques is found. And even NISORA, which is one of the quite popular websites for regional anesthesia, has come up with this triple monitoring, where monitoring with all the three definitely provides a much safer margin. Many equipments are also available through which we can monitor the pressure. At the same time, many people have also come up with various techniques in which each individual can practice how to check the pressure while injecting the drug. These are available in the internet and anyone can look through it when interested. Block failure. Block failure is almost like a heart failure for any regional anesthesia practitioner. But please remember, it's very common. Even the best of the best anesthesiologist has to face it. And if somebody says they never had a block failure, they would be lying to you. And even the statistics say that even if you have done the best epidural, there is a chance that 20 to 30% can fail. And please note, most of these are secondary causes, not primarily. Once the catheter is placed, there are so many issues because of which the catheter doesn't lie down. So it's always better to have a plan B. What if it fails? So when we are practicing this regional anesthesia, one of the recent evidence-based update which I saw was, there is an article in 2022. So whenever you're doing a block, ultrasound regional blocks, this article gives an idea regarding the minimum anatomical structures that needs to be visualized. Each simple block, minimum what all should be seen. For example, if there is an axillary block, a conjoint tendon, axillary vein, the three nerves, all these should be compulsorily seen before practicing the block. So this gives a very simple idea and a very safe way to practice blocks. The other update was regarding the antithrombotic drugs. Last guidelines was in 2015. Not much changes have been, but the European Committee came with the 2022 guidelines. The main focus was here about the high dose, those patients who are on a high dose antithrombotics, and especially the deeper blocks. And whenever we are anticipating a deep hematoma. So these were the primary groups which were targeted. And honestly, there is not much of changes in the duration of stopping of antithrombotic drugs. But what was important point is, since most of the people are practicing ultrasonography, they might believe that they are giving a good amount of drug in the real time at the right place. So can we be liberal with this duration? So the guidelines have clear cut said that please don't be liberal with these guidelines. No matter whichever technique you are using, one has to adhere to the duration if they are on antithrombotic drugs. Often I believe when we are practicing a regional, we believe we are doing the right thing. We are doing everything for the sake of the patient. So we hardly are going to do any errors. But honestly speaking, we all fall into this error traps. Most of it is unintentional, but there is a nice, interesting article which speak about some of the traps which we fall into. Mainly like this site. Ever since the checklist has come, the side of the surgery is easily identified. But with ultrasonography, one of the common problem that has arisen is the site. Maybe, for example, choosing the brachial plexus block for the right kind of surgery, the right site of the surgery. And second thing is, all of us are quite well versed with ultrasound anatomy, but most of us are not so well versed with ultrasound artifacts. They're equally important. And when a regional anesthesia should be chosen as option, when it should not be chosen, that is another trap which we usually fall into. And often, whenever there is an extra need of another imaging technique like fluoroscopy, neuromonitoring, we have to take aid of them. And sometimes it is difficult for us to just stick on to one particular regional anesthesia technique. For example, if an AMC child comes with an upper limb surgery, most often it's difficult to choose for supraclavicular because the anatomy is distorted. So even though we might think that supraclavicular provides appropriate site surgery, we might have to end up with an interscaling because the abnormal anatomy is contributing. So alternative block for an abnormal anatomy is another error trap which often we fall into. There are some newer advances which have come. Interfacial blocks have become very popular because of these two important reasons. One is the blessing of the COVID-19 and our hope on ERAS protocol. If you see, a lot of interfacial blocks are there in the market right now. But please remember some relevant points on interfacial blocks. It is still novel technique. We need to know more about it. And never use interfacial as a single mode of analgesia. Always use it as multimodal because it never provides visceral analgesia except for the QL block. So it's better to add something else along with this technique. And it is a volume-based block. So whenever we talk about volume, immediately we need to remember that there is a chance of toxicity parallelly happening. And in pediatrics, there is a huge variation. Even if you consider a simple hernia block, people have done many studies and seen from a 2-year-old to 17-year-old boy, where the inguinal the ilioinguinal and the iliohypogastric nerve lie, there is a huge variation. So with such varying anatomy, interfacial blocks could not be used so liberally. The other update which has come recently is a liposomal bupivacaine. Bupivacaine has come in the market in liposomal form, and the companies are claiming that just one use, we can just give it as one infiltration and it stays for 2 days, and there is no need to repeat the dose, everything. So a lot of benefits have been said, but some people do claim that they're using it even in children more than 6 years of age group, but most of it is just infiltration and facial block. So it has to be used with caution. Chlorprocaine infusions are coming back for neonates and infants. Actually, previously it was used because of one of the side effects secondary to the preservatives which was used in the drug. It was stopped, but now many people are coming forward because it's an ester local anesthetic with a very short duration of action. Infusions are quite safe. So chlorprocaine is back. The other ignored group in regional anesthesia is the surface anesthesia. We have been using EMLA from many years. So now there are so many preparations available in many flavors. They are available, and not just EMLA cream. There are many Cetacane, Precane. So maybe we need to explore them, not apart from dental and ophthal, also in other arenas, not just pharmacological, even non-pharmacological techniques of service anesthesia are coming, like pre-cooling, TENS. These are areas which needs to be explored more. There are a lot of improvements and advances. I'll leave this question to you audience, whether how far have we come with regional anesthesia. Regional anesthesia, e-learning has started. Regional in viral infections have been a promising view. And what I like the most is how can we improve periop compliance and quality of care. Old blocks are coming back, technology is helping, ERAS protocols are coming, the evidences are just climbing up like a pyramid each and every day. Often when I look through a lot of data and information, I always end up asking myself this very important question, after learning so much, what next? So I always believe when we have learned so much, the next step which we should start is what should we unlearn ourselves? Why I said this is because there was an interesting article recently I saw regarding the present day concerns because of so popular nerve blocks that is happening. We all are so busy and so enthusiasm based practice that we subconsciously have developed a complexity bias. If you look through keenly, most of these blocks have just a clever acronym or a different name. Like, for example, the PEX2 or the serratus anterior block, there's a marginal difference between them. But with the new name, new techniques, we all feel that it's very enthusiastic to practice, publish it, and get as a novel publication. So in this hurry, we are looking through unproven, under-researched, and unvalidated data. So this is where the present day concern is lying. So we need to change ourselves, look at regional anesthesia, not with a perception of novelty. We need to make it a core component of anesthesia practice, make it like airway management, IV line practice, balanced anesthesia. So these authors suggested one beautiful suggestion in this popularity of interfacial blocks. They said just divide all the blocks simply into plan A and plan B. Let us all practice and well verse ourselves with basic blocks first. Even when we teach to students, let this be a way in which we can practice and then step up to advanced blocks. A lot of patient safety and periop compliance will be achieved by this way, and lot of barriers can be overcome. I know one of the biggest barriers for practice of these blocks is surgeon. But apart from that, yes, we can overcome all these blocks if we do a protocol based and a nice way of practice. This is my last slide. I just want to say that let's not think regional anesthesia as some quantum physics. Let's change from many blocks for a few to few blocks for many. Let's focus on more high value nerve blocks. Let's make it a core component. And developments in regional anesthesia is not going to stop. It is going to happen every day, but our perception of looking at it should let it be more pragmatic. And I never stop asking ourselves this common question: do we really need more blocks, or shall we learn what we already have now more? These are my references, and thank you for all your patience.
Bhagya, thank you so much. That was exhaustive, but a brilliant talk. And for all your tips and tricks on regional anesthesia, I hope our audience and myself will try to adhere to whatever you have suggested. So my next speaker is Dr. Nivedita. I have had an opportunity to interact with Nivi again while I was doing my fellowship. So currently she's an assistant professor with the Department of Anesthesia, Perioperative Medicine and Department of Pediatrics at University of Western Ontario. Her interests include pediatric anesthesia, acute and transitional pain, regional anesthesia, women in medicine and healthcare workshop. She's I think she's a high achiever. She has 3 fellowships, 2 in regional anesthesia and 1 in pediatric anesthesia. She's been part of the recent successful workshop conducted at the Society of Pediatric Anesthesia at Austin, Texas. And it was like super successful because I saw it so many of our feed on the Twitter actually. Nivi, I'll just hand over the stage to you.
Good evening, everyone. Thank you for joining us today, and thank you to the organizers for having me. I'm going to be talking about the challenges in pediatric postoperative pain management. The objectives of today's talk is to list a few challenges in the management of pediatric postoperative pain and discuss a few solutions to these challenges. Let's first look at the impact of poorly managed pain. This is seen at various levels, starting with the patients themselves who have physical and psychological suffering. Mismanaged acute postoperative pain can lead to longer recovery and hospitalization. It increases the risk of complications and infections. It could lead to unplanned readmissions and emergency room visits. Inadequately treated acute pain then increases the risk of chronic post-surgical pain. The incidence was noted as 12 to up to 40% following surgery at the end of 1 year. At the level of the hospital, poorly managed pain is an indicator of failed hospital policies and failure to meet standards of care. As physicians, we fail in our responsibility to do no harm. Ultimately, there is a big financial burden at the individual level as well as to society. With increased healthcare costs, absence from work leading to loss of income for caregivers, being away from home, all of these increases the financial burden. And in total, it is important for us to acknowledge the impact of poorly managed pain. So what are the challenges in pediatric pain? I have them in 7 categories, starting with age. So pediatric is unique in the fact that we deal with a very wide range in age. We deal with neonates who can be term or preterm, to infants, toddlers, and teenagers. And in that population, very few actually qualify as little adults. There is lots of evidence recently that indicates pain is felt even in the fetus, and these noxious stimuli shape pain experiences in development. Age influences physiology, pharmacology, psychology, and then pain management strategies themselves. For example, doing a regional technique in an infant versus a teenager is very different in terms of the dosing required, the equipment that we need, the skill and monitoring block. So what I'm trying to say is that we cannot just take or adopt a standardized studied adult model and expect it to be successful in the age group. Copy and paste or a face swap will not give us a pretty picture. A second challenge that influences perioperative pain is the surgery. No 2 surgeries are the same, and 2 people will not have the same experience of pain, even if they have the same surgery. That is the subjective nature of pain. Some surgeries qualify as major based on the duration of surgery, the extent of the incision, or the anatomical derangements, and some are minor. So all surgeries and surgical pain cannot be treated the same. Basically, surgeries can vary in pain intensity, and it's interesting to note that surgical techniques also influence pain. The type of surgery is one of the risk factors for chronic post-surgical pain. For example, scoliosis, thoracotomies, hernia repairs are known to increase the risk of chronic post-surgical pain. These surgeries require active interventions to make sure this does not progress to chronic post-surgical pain. The next challenge is that children are non-verbal. This could be because of age. An infant is not going to tell us where they have pain or communicate the intensity of their pain. Or the child could be non-verbal because they're developmentally delayed or they do not process or communicate pain normally. They could also just be shy or stoic and not have a vocabulary to communicate their pain. Crying is the most common method of letting us know discomfort, but that could mean many different things. They could be unable and or unaware on how to express themselves. And as providers, interpreting their cries, behaviors, and noises is a challenge on if there's pain, where it is, and how much of that is attributed to pain. The next and important challenge is pain assessment. We are all aware that the cornerstone of good pain management begins with pain assessment, but remembering that pain itself is a very subjective feeling. There are various tools which include self-reported scales, observational scales, and physiological scales, like FLAC, the visual analog scale, numerical scales. Those are the ones that are commonly used for assessing pain. Most of these scales lack specificity, And though they're designed to be objective, it is still measuring pain that is in its very core, very subjective. It is also important to remember that in doing these assessments, we are looking for trends and not a single number. For example, a child could be sleeping and the flat score would then be 0 or 1, but that doesn't mean the child does not have any pain. The same way, a screaming or crying child could also be that they're disturbed due to something other than pain. They could be hungry, they could be too hot, too cold, be in an unfamiliar place, or lacking the comfort of home and a caregiver. So it is challenging to quantify pain in children. Children are non-autonomous, meaning to say that they have substitute decision makers in parents and caregivers. In addition to dealing with managing a child, the pediatric world is unique, where we have to extend our services to the caregivers as well. We do somewhat rely on caregiver reports, so their beliefs, attitudes, and biases influences treatment plans. Some caregivers could be reluctant to report their child's pain due to fear of being labeled troublesome. There could be conflict between cultural beliefs and science. Children also look to their family members for support, and their family serves as their advocates. So some caregivers could just be very hands-off and have the healthcare provider take care of everything. So there's lots of potential for the parental anxiety and catastrophizing that can impact the pain management for the child. Next is the psychology of the child. Many children express being anesthetized as stressful and anxiety-inducing. They feel powerless and vulnerable. Of course, age influences this greatly. Being anesthetized itself could be understood as a threat to life by preteens and teenagers. For example, I did a case a while ago of an 8-year-old child who came in for an upper limb surgery. This was a very cooperative child, very chatty in pre-op. We had a good rapport, and we decided to do this case under some sedation and an upper limb block. The surgery itself was uneventful. The block was working well. He received multimodal analgesia. However, in recovery, he was crying and inconsolable, and I was called back pretty quickly to see what was going on. It took a bit to calm him down, and luckily popsicles helped in this case. And on asking him what was bothering him, he said he couldn't feel his arm and he didn't know where his arm was. And then it took lots of calming and pointing to his arm to say it was there. And that's when I understood that that age group, the 8 to 10-year-olds particularly, they fear losing a limb. And the same as with preteens and teenagers fear for their life. They fear they won't wake up or they fear death. So it is important for us to understand this in choosing a pain management strategy appropriate to the child, and also provide them education and understanding their psychology. The last, but certainly not the least challenge, I think, is the provider or us. We as healthcare providers have our own biases and attitudes towards pain. We have our own classifications of what procedures might be painful or not, and hence dismiss pain that's being reported, forgetting that pain is subjective. We could be having a bad day, or we could get a call from work after hours. And so it requires a lot of work and self-motivation to treat pain efficiently. There is also lots of focus on opioid usage, or rather overusage. Lots of talk about opioid phobia and misconceptions, lots of skepticism of addiction and other side effects that we don't use opioids appropriately. We also vary in our awareness and knowledge about various pain management strategies, clinical inertia or slowness to update individual practices in the light of evolving evidence all affect management of pediatric pain. So how do we address these challenges? We need to reduce the knowing to doing gap, and this can be done by following the 3 steps. We need to move from awareness, acceptance, towards action. Awareness and acceptance comes from participating in knowledge translation activities, reviewing literature and following trends and putting them into action by implementing various strategies. Without going into much details of pain management, I'd like to highlight some points. It's important to be planned and organized, open communication channels between caregivers, the surgical teams, and the perioperative team. Make sure we assess pain in regular intervals, and also give clear instructions on pain management and good pain education to the patients and their family. Our goals remain to decrease pain and suffering, minimize side effects, increase well-being and comfort, educate patients and their families to communicate about pain. We need to remember management is guided by assessment and to use multimodal and multidisciplinary approaches. The cornerstone of pain management is pain assessment. Again, we do not treat a number, but we are looking at trends and we want to see a trend that is decreasing or declining. For a good pain assessment, we need to use an appropriate tool, which is age appropriate. It can be a VAS, FLAC, or a numerical score. We can include parental or caregiver report of pain, and sometimes it is used as proxy. It needs to be timely and regular. It needs to be every 2 to 4 hours to follow a trend. We can't just have one score in the morning and one score in the evening. It needs to have other details, whether it was recorded at rest or with movement, if other things affected the pain, like change in posture, change in mood, sleep. All these things need to be documented, and only then can we develop a good management plan. Ideally, all pain management strategies should follow the 3P approach. This was initially used for chronic pain management, but is now being used in acute pain and in prevention of chronic pain. It has both pharmacological and non-pharmacological management strategies. So let's look at what the 3P approach is. It is basically the biopsychosocial model of pain management. The first P is pharmacology. We want to have order sets or protocols that are standardized, making sure we optimize medications, which mean the right drug, the right dose, the right schedule, and the right route. Many institutions have surgeons who take over postoperative pain management. And a recent study actually showed that 60% of patients received medications like NSAIDs and acetaminophen around the clock following surgery, meaning to say 40% received these useful drugs only after complaining of pain. We need to stay on top of pain, not chase it. So order sets and protocols are very important. And following pain ladder then helps to increase or decrease these pain medications appropriately. The second P is physical therapy. We're not talking about strenuous exercises or lifting weights. It is simple things like changing position, sitting at the edge of the bed, a few steps around the room, and also using heat and cold therapy or compresses, massages, and TENS. All these things contribute to physical therapy. The third P is the psychosocial component. What is most important is pain education, setting up expectations and pain goals, and empowering them to communicate about pain. Other things we can have them do is use distraction strategies, which could mean listening to music, meditation, watching TV, a phone call with a friend, spending time with their families. All these things add to the psychosocial component of pain management. We need to plan these pain management strategies to fit the circumstance, need, and the response of our patients. It is important to have a universal design. This ensures that every patient undergoing a particular surgery receives the same protocol, making sure it has multimodal analgesia and incorporates the 3P approach. It would ensure they receive the correct dose in the right time interval, irrespective of who the provider is. This protocol can then be escalated or de-escalated as appropriate. Recently, the European Society of Pediatric Anesthesia released guidelines and introduced the LADDER initiative that includes protocols for various surgeries with drugs and dosages, and escalation and de-escalation plans. We can use the WHO ladder to help with the designing of these pain protocols. And ultimately, what we are looking for is to ensure we give the right dose, the right route, the right schedule to keep the child comfortable. So our take-home message today is that we looked at the challenges of managing pediatric postoperative pain and looked at some ways on addressing these challenges. Thank you.
Devi, thank you so much for that sincere and very thoughtful lecture. It was quite I mean, obviously challenges are so many and you so beautifully covered the whole thing. I just want to find out from Dr. Addy if we still have time. I think we have we're up 1.5 hours up. Can we just still go ahead and take a couple of questions?
Yes, another 15 minutes, I guess.
Oh, lovely. That's great. So I think at the end of this, the recurring theme is, perioperative pain management in children should be a priority for us. So in this regard, I would specifically like to ask one question to our panelist, Dr. Chandrika here, who is also my mentor and the head of the department at the Institute of, Indira Gandhi Institute that I work. So, Madam, I just want to know, what are your comments on how do we change institutional practice so that, there is no child who's left back or whose pain is neglected?
Yeah, thank you, Anu. Can you hear me?
Yes, ma'am, we can hear you.
Yeah, it's a very good question. Institution like us, which is owned by government, it's very, very difficult to make everybody to follow a protocol. So whenever you say about pain and pain relief in children, and every child who comes to the hospital should get pain relief, I think there should be a multidisciplinary approach. That means to say, we should involve other allied branches like surgical branches, medical branches, intensivist. Everyone has to be involved. So first and foremost challenging is to gain the confidence of other specialty. And I think first of all, we should orient them towards the pain perception in children and what are the disadvantages of pain in children and what are the advantages giving analgesia to all the children, how it's going to help improve the morbidity, mortality, discharge from the hospital and all other things. I think all the speakers have already explained. So that's the most important challenge. And next important challenge is to make a uniform protocol for each and every procedure what we do in the hospital, whether it's a surgical procedure or non-surgical procedure. So we should have a uniform protocol depending on the availability of the resources, whether it's a human resource or whether it's a equipment or whether it's a drug. So we should have a protocol which has to be followed by everyone. And next most important aspect is developing acute pain services and APS team in the institute. So at the institute level, we should have a APS team. So as far as APS is concerned, I feel if all the anesthetists are involved in APS team, then it will be very good. But if you have some problem with the human resources, then we can make use of surgical residents and pediatric medicine residents, and we can explain them their roles and responsibilities, especially for follow-up of the pain after the surgery. So that they will assess the pain score, and they will assess what is the pain and is there any need to give rescue analgesia for breakthrough pain. If you don't have that resource also, I feel we should educate the parents and the nursing staff to assess the pain and follow and the nursing staffs can follow that protocol of giving prescription for breakthrough pain and all other things. So I think with this, once we do all these things, I think it will be very easy to follow, and each and every patient who comes to the hospital will be pain-free, and we can say that our hospital is a child-friendly institute. At this junction, I would like to say that we have a acute pain services department in our institute, headed by Dr. Anuradha, and they usually look after both chronic and acute pain. And we have an outpatient-based pain clinic also in our institute. And shortly, we are going to start chronic pain or cancer pain therapy also in our institute. So I think this is what is important, Anu.
Thank you, ma'am. Thank you for your wonderful feedback. Yeah. Dr. Eddie, what do we do? Like, I'm happy to take, there have been a lot of questions, but I would say I would be happy to listen to whatever you have to say. You can take the lead.
We still have time, I think. There is the questions that Dr. Raylene wants to answer it live. It's
Yes.
about it's regarding the device that can assess pain in neonates.
Yeah.
Dr. Raylene, please.
Yeah. So we have used if you want a device, we've used the neonatal infant parasympathetic evaluation device. It's almost similar to analgesia and nociceptive index, but this is specifically titrated for neonates, and you can use it in preterm babies as well, right up to 2 years of age. So you get it's a monitor. It's manufactured somewhere in France, and you get a cable. You attach one end to that monitor and the other end to your whichever monitor you're using to monitor the patient perioperatively. So it extracts the ECG from there, and it calculates the parasympathetic index based, the autonomic component of, and it basically computes the level of distress, and they use that as a surrogate measure of pain. So the values are just the opposite of that, like BIS, like higher values means there's very intense pain, like intense analgesia, like values above 80. So you can come down on your analgesics, and 50 to 60 range is what they recommend to keep. There are studies where they have shown that it correlates well with the other pain scores when they have used it post-operatively in the NICU. But still, there are we just did a study on 15 patients, so we were not able to actually properly assess it. But we found that it did correlate with other parameters intraoperatively.
Yes, we know that it's really difficult to assess pain in neonates. Dr. Nai, do you have any comments about that?
For assessment post-operatively, there are specific like tools that can be used, like the NIPP, and there are other ones that are available. I think different NICUs use different. I think our NICU use NIPP. I'm not sure what other hospitals that you guys work at use, but they're quite correlates quite well with the patient's pain level, although they're not self-reported, but they are available.
Dr. Nivi or Dr. Nai, can I please ask you to just briefly tell the audience about the transitional pain clinics that you have in the West? I think they're simply amazing, and this is some concept which we should also start doing in the East, probably. Anybody, anyone, either Nivi or Naya.
Do you want to go, Nevi?
Yeah, sure. Transitional pain clinics, I think the main, we are in the initial stages of setting this up. We try to incorporate the 3P approach, and the target population is kids coming for elective surgeries that are known with to have high risk of developing chronic post-surgical pain. So what we're doing is developing these multidisciplinary approaches so that we give them some prehab, make sure that children already know what exercises to expect, what they're expected to do. We optimize their pain medications, if any, if we want to start preemptive analgesia, or we, so that kind of education takes place. We have lots of pain education. It can happen individually or in groups, or give them resources for these pain educations to set those goals and what to anticipate. We have Child Life walking them through the surgical procedures and everything else, so that they're not very anxious on the day and they know what to expect. The biggest aim is, given that the opioid epidemic that we have, is to make sure that we taper off those opioids by the end of 2 weeks, and then we follow them up until 3 months to see whether they are developing chronic pain. So we've had around 120 patients so far in implementing this clinic in 1 year, and we're happy to report that we had 85% of patients were off of opioids at the end of 2 weeks, and nobody went on to needing a referral to chronic pain. So there's definite positive effects in just following a 3P approach and ensuring that universal design for all these kids, especially the ones that are going in for major surgery.
Awesome, Nivi. Thank you so much. So it's more like a prehabilitation where you educate the child, the parent, set expectations, and then tackle the pain using the 3P mode, right?
Correct. Yes.
Dr. Naya, I have a question for you. So could you please tell us about like use of muscle relaxants especially in orthopedic procedures in children? I still see that there is some hesitancy on our side to use muscle relaxants in children. So could you please clarify?
Yeah, for sure. So for postoperatively, for a lot of very extensive orthopedic surgeries like spinal fusion or kids getting hip osteotomies, they often have pain that's more associated with muscle spasm that opioids doesn't treat very well. So for those kids, they may need muscle relaxant in addition to just opioids for more of the incisional and regular postoperative pain. So for example, for spinal fusion, we often start kids on methylcarbamol, which is a little bit of a weaker muscle relaxant, and they can be weaned off pretty quickly off it after surgery. And for severe pain for the big hip surgeries where there's a lot of large muscles, they may be started on IV diazepam for the initial post-operative days, and that seems to be quite effective. Thanks.
Thank you.
Thank you, Doctor. Teddy,
when we started using methacarbamol here, our orthopedicians weren't even aware of the drug. But then slowly, when they realized it helps, it's come into practice now.
Yeah. Thanks, Ralin. I think I'm going to convince our orthopedicians here.
Yeah. I think we have run out of time. I think Dr. Anu, you may close the meeting.
Okay. Thanks to all of you for being with us for the last 1.5 hours or so. It's exhaustive. It was a great learning experience for all of us. Like I told, the recurring theme was, perioperative pain management in children should be a priority for all of us, not just because they're small children. We need to be the fiercest advocates to ensure that they're pain-free. And please send in your feedback to us. You can use this QR code and do send in a feedback as to how we can work on our improving our content better or provide what you are more interested in listening to. And a little bit about our next webinar. This is Dr. Harry, can you please share? Yeah. Oh yeah, this is just in case a few of you have missed. We had like 625 registrations. I'm sure a few of you have missed it. So please feel free to go back and look at all these resources, and you can probably listen to the recording again. Just to quickly remind you that our next webinar series is on neuropathic pain in children. This is going to be held on the July 8, 2023 at 5 p.m. Singapore time. And also a reminder about the Asian Society of Pediatric Anesthesia annual meet, which is this is the 19th ASPA conference, taking place between 16 to 18 June. This is in Seoul. So we do hope to see quite a few of you there as well. Yeah, thank you so much.